All right, so I think we're going to get started. It's 1 minute after. So welcome to our first quarter 2023 Baltimore CCT Collaborative. It's always great to get the two teams together. And like we were just discussing, I think we're going to be adding in Christiana on the next one. So we're excited to have them join this group and maybe bring some cases from them. And always great to kind of share the knowledge across town, because we're all trying to do the same thing and take care of these sick people. So our friends at Maryland Express Care brought us an extremely sick case today. So I'm looking forward to this discussion and getting everybody together. This will be Dr. Launer and Cody will be sort of spearheading this and leading this. So Asa and I will pop in from time to time, but it's going to be mostly y'all's show. So quick intro to who's on the panel. So most all of you guys are know who I am. I'm Sam Matei. I'm one of the lead clinical nurses here over at Lifeline. And I'll be sort of emceeing this to a point, but like I said, this is going to be Cody and Ben Launer's show. So I'll let them introduce themselves, and then we'll let the docs on my side introduce themselves.
All right, man. My name is Ben Launer. I'm a big fan of Sam and Asa. So I do medical direction for Maryland Express Care Air and Ground in Baltimore City. I just want to say thanks for the opportunity. This started as, I think, an idea many months ago. And I know, at least speaking for my crews, it's been excellent. And despite how complicated, messed up some of these cases are, I think we really enjoy the ability to kind of talk about it. So that's credit to you, Sam, and the educational mission. Definitely something we really enjoy. So I will try not to embellish, only a little bit, but thanks for being here. Cody Winifred.
Hey, what's up, everybody? I'm Cody Winifred. I'm the base manager over here for PHI in Baltimore. Looking forward to presenting this case and see what we can tease out of it.
We do, and Sam, we are very lucky to have our assistant medical director here. So I see Jeff, he's going to be very modest, but yeah, there you go.
I'm here. I'm so disappointed you're not in a flight suit. I'm actually just getting back from throwing up because the disappointment's overwhelming. I'd say you go put it on and come back, and then we can continue this.
Asa, I think that's your cue. So you and the team from here at Hopkins.
Not to be outdone by Jeff Nussbaum. Good morning, everybody. Asa Margolis. Agreed. This is one of my favorite things that we do as a group, and definitely looking forward to including other programs as we continue to move this forward. Cody and Ben, thank you so much for bringing the case this month, or this quarter, I should say. I heard it's a doozy, to say the least, so I'm super excited about getting into it. And I guess we'll go with the rest of the team. Ruben?
Morning, everyone. Ruben Troncoso, one of the assistant medical directors at Lifeline. Happy to join.
Eric?
Good morning, Eric Garfinkel, one of the assistant medical directors at Lifeline. Glad to be here. Thanks for having me.
Awesome. Matt?
Hey, good morning, everybody. Matt Levy, associate medical director at Lifeline. Good to be here.
Kosh?
Good morning, Kosh Call. I am the EMS fellow at Hopkins.
All right. And then last thing, I put up a CME number for physicians to get CME credit for this. If you're not in the system, I will get with you after to figure out how we get you in our system. And then for all of these collaboratives that we do, you can get CME credit for it.
Got a lot of Hopkins docs. We got to get the thesaurus from the man.
I knew that was coming.
County can translate, maybe.
Actually,
I would have been disappointed had there not been a discussion of how many physicians the Hopkins team brought.
And Sam, not to forget, we have a couple of our residents on, so we should
nice
that they're here as well.
Oh, good.
So Kiri Morris, in fact, Kiri is actually doing EMS fellowship next year. She'll actually be focusing on air medical, so this is great to have her. Alex Vaughn, another one of our residents interested in EMS, and Jenna is the intern who's on our EMS rotation for these 2 weeks. So as the rest of the physician side on the Hopkins side of things.
Welcome.
All right. Well, now that we got that out of the way and Ben's made his crack about how many how many medical directors do we need to run this team? It's like a bad joke, right? All right. So Cody, I'm going to let you take it from here and intro your case.
All right, we've got a pretty interesting case for you guys today, a non-traumatic hemorrhagic shock patient. This is a patient from, I think we did this one in 2021. So you'll forgive us for some of the details not being as fresh as usual. So let's get into it.
So there's your dispatch.
Yep, got the call for a 32-year-old female, postpartum hemorrhage, and I believe maybe possibly there was a note about a ROSC in there as well. But this is what we walk into.
So I guess my question to the group is if and to the panel, if this is the call that Cody and I get, we're working on the aircraft that day, we get this call, what do you want us thinking as we go out the door? What are the potential differentials, right? You've got a postpartum hemorrhage, they've gotten ROSC. We always get sort of bits and pieces of the story ahead of us getting there. I've heard the joke that EMS is making decisions with inaccurate information and you can only believe half of what you get as true. So what are your thoughts and what do you want Cody and I thinking as we head out the door for this patient? Jeff, what do you think?
So there's a couple things. I mean, the first thing I think I'd like everyone to remember is how stressful this is going to be. I mean, obviously, critical care medicine is incredibly stressful. You never get invited to good times, to parties. But a new mother who's dead or about to be dead is almost as bad as the child being dead. It's like up there. So I think the first thing everyone needs to do is take a deep breath. The check your own pulse situation. It's easy to get in the tunnel of we're practicing medicine and then you walk into what's a complete mess. And the elderly patient with septic shock is unfortunate, but it's not the same level of emotion that runs on a call like this. This is also like postpartum hemorrhage is very common in the developing world. It's not something we see so often in America, so it's not something you encounter as much. So there won't be so much familiarity. The other thing, blood products are available at different venues. I don't know exactly how much blood you carry, but this is a situation whenever you're diagnosed or you're going for a transport where the diagnosis is hemorrhage of any kind of hemorrhage, you need to bring all of the blood, whatever gets all of the blood with you. For the aircraft, it's probably stored there. For Hopkins, I don't know if you guys go retrieve it from somewhere. From Maryland, we go retrieve it. So get all of the blood on this one. And then the last thing I think is, we often talk about what can stay in a sending facility and what really needs to go. The ultimate endpoint to a postpartum hemorrhage that cannot be temporized is an unfortunate hysterectomy. And it should just be in your mind that if things are going really, really, really poorly, most people that can perform C-sections would be uncomfortable, but can technically and feasibly likely perform a hysterectomy. And I'm not telling you need to be thinking your way out of every case, ways to not transport people. But I think it's always important if you're walking into something that's really, really bad and can be managed at the sending facility, it's good to keep that in your back pocket as well.
So Ruben, Hopcom calls you in the middle of the night, wakes you up, or you're probably awake because you're a night shift guy. But what are you telling them to? Are we going to the blood bank and getting the blood? Can I get more than just my 2 units that we typically pull?
Yeah, I think that, these patients are famous for going into DIC. So I don't know what's going to end up. I should say this. I know you're definitely going to need blood, but you're probably going to need a lot more than just blood for these kind of patients. So I'm probably going to be chatting about what our options are for FFP, for platelets, for cryo. I don't know if that's going to be available to us. We maybe have to coordinate with the sending facility to see what kind of blood products they have for us as well. But yeah, you're going to be taking a lot more than blood if possible.
Okay. Anybody else on the panel got any 132 cents in there before we move on?
Of course. Shocking, I know. I agree with everything that was said by Jeff and Ruben, for sure. Ruben mentioned something that I thought was pretty interesting that we tend to sometimes gloss over, which is cryo. So we think about doing, a lot of units of blood and getting an MTP cooler, and we also need to think about the things that we don't think about all that often, which is cryo. And if this patient ends up going into DIC, which they may have a high likelihood of, they're going to obviously need cryo. And even if they're going to be getting a ton of units of blood in an MTP fashion, right, we got to think about calcium. Do we have enough calcium? And do we have enough cryo? So there's other things that sort of go along with MTP that are sort of like the ugly stepchildren that we don't always think about as much.
All right.
All
Cody,
right.
back to you.
So this is the bullet, right? So it's an ICU to ICU transfer. It's a 23-minute flight, about 45 minutes via ground. It's a 31-year-old patient. She's 37 weeks and some change. She's due for a C-section in 2 days for Creta. She had a syncopal episode. So her husband and her drive up to a gas station. She has a syncopal episode in the front seat after having a severe episode of abdominal pain. EMS gets there and finds her asystolic arrest. They get ROSC on scene and transport her to their closest ED. Next. In the ED, she rearrests 2 to 3 more times. The story was a little fuzzy on that. They find a placenta previa. There was an emergency C-section performed. The fetus was not viable. She was taken to the OR for further evaluation for bleeding. The total hysterectomy was performed. They still did not find the source of hemorrhage, and they started massive transfusion protocol. In the ED, she got 15 units of red cells, 4 units of FFP, 2 units of platelets, and I believe, since we're talking about cryo, no, she didn't get any cryo in the ED. Hemorrhage was not controlled still, and she goes up to the ICU. ICU, we're on the level 1 infuser, a 6:4 to 1 ratio. They get vasopressors up. She's at 70 of levo, 20 of epi. Vaso's going in 2. She's on a bicarb infusion. Her abdomen is still open. There's 2 RNs that are also holding pressure on the vaginal opening. We heard a report initially of over 100 units had been administered over the last several hours. So we get there about 7 or 8 hours after this incident, after she presents to the ED. She also got 2 grams of TXA, 10 milligrams of factor 7, total of 22 grams of calcium. They get the vasopressor support down prior to our arrival, and we're maintaining MAP. So I want you guys to kind of like key in on this. We're maintaining MAP. We're not on vasopressors after having come down off of 70/20 and vasopressin, excuse me. And blood is on the level 1 infuser. This is the situation that my partner and I walked into. Next. Okay. So for the panel, when you hear that we're going to call you, right, and go, hey, I'm in a jam. This is what I got to deal with. Dr. Launer, what do you got for us?
So this is and I'd love to hear I don't want to steal the thunder because obviously I was involved in this case. Thank you so much for this call. This was a wonderful exercise and lots of controlled thinking. But I have to say, we pride ourselves on clinicians in terms of doing this. This is what we do. We are the experts, but I think it's another level of expertise to realize when we're all out of our depth, right? This is something we don't routinely deal with. And I want to say there's a couple of keywords, and Cody had a couple of them for me. So when the phone rings off, he's like, "Hey man, I'm in a little bit of a jam. I want you to talk me off this ledge, man." So the issue is, I get a call about a patient who is actively hemorrhaging to death in a facility with definitive care, with surgery, already in ICU, who's hemodynamically unstable. And we're already our backs are against the wall, right? So this is where we start thinking about contingency. And this is where I think in this case, there's so much to talk about, but it also requires a little bit of something that we do, I think, very well as critical care clinicians, which is thinking outside the box. So the minute you hear you have so many variables that you can't control, we really began a conversation of what is it that you need? What is it that the patient is not getting? And how do we get you help? Because I was confronted with a situation in which you had somebody on a level 1 pressure infuser, and not even a state police with an AW139 will be able to carry that right to the patient's bedside. The patient is dependent upon the level 1 pressure infusers and the vasopressors, and they're actively hemorrhaging. So I want the case to unfold because it's a ground piece, but what I would just say is, I think we recognize very quickly that it is, I think, the cornerstone of humility and professionalism to say we need help, which is the thing that I said to myself immediately after hearing I'm in a jam.
I think that's a new phrase, a new level of hemodynamics, that you're
I've been
stable
saying
on a level 1. Stable on a level 1. It's like
stable on a level 1 infuser, correct?
yeah, stable asterisks, like 10 asterisks.
Yep. No pressure requirement as long as she's not getting a unit of blood every 30 seconds.
That's pretty much the case.
Dr. Levy, all my first line medical directors go on vacation, and they tagged you with covering down. What advice are you giving me when I paint this picture for you?
Good morning, everybody.
What's up,
Thanks,
Matt?
Sam. Appreciate the opportunity to help and serve. Yeah, listen, these are really messed up situations. So I guess to slow it back down for a second, I would want to say, Cody, all right, so tell me, so as of right now, what is our most expeditious way to get this patient out of there is, I think, the first thing I want to know. And what additional resources do we want to get? Does he feel like he needs to be successful? Is it more people? Is it more resources? Because clearly we're fighting a losing battle at this point. And the other thing that I think it's important that I don't really have a good sense of is, if I missed it, forgive me, where are we losing blood from? Do we even know at this point, guys?
We don't.
Okay.
Yeah, the patient was, I can tell you the patient was actively hemorrhaging from her abdomen, actively hemorrhaging from, I believe, the vaginal orifice, other sites. So there were quite a few places, but at that point it was not known. The patient obviously was too unstable, for your to your point, to get a CAT scan.
Yeah.
So it was not clear, but it was also very clear that whatever she was getting in, a lot of it was coming out.
And we have an open, do we have an open abdomen at this point, guys?
Yes, sir. After I was in place.
All right. Is Reboa a possibility?
Not for us, but
No, in other words, like, yeah, fair enough. Okay. But like, in other words, is this a center that has that even has Reboa, the facility she's at, or what type of resources do they have? Because we have to, sounds cliche, those of you who get the joke, we have to stop the bleeding, right? We have to do something to get this bleeding under control, to get her stable enough to get into the aircraft and up the road, up to Baltimore. So what are our options? What resources do we have available at this point in time?
for mechanical hemorrhage control, we didn't have much. I think what was in place was what was available and what we could, what the sending facility could put together for us.
I would imagine they were at the end of their rope, correct, Cody? And I remember hearing Dr. Scalea say one time that he doesn't even listen to the consults when they call. He just says yes, because if somebody's calling, they're at the end of their rope. Yep. So I would imagine that's the situation that we're in here, right? They probably don't have Reboa. They've thrown all of the hemorrhage control assets they have at this patient.
Yeah, no, I think that's right, Sam. I guess it might, to follow that statement up, right now everything that's being done isn't working, including taking her uterus out.
Sure.
So we need to I think we need to move from a truly into a full-on damage control strategy, which is not something we necessarily think about in medical resuscitation as much. But that was the question behind my question. So okay, so yeah, go ahead.
Matt, I don't know. The Reboa is something I've been thinking about as well. And if Sam or Cody shut me up if we're going to get to it later. But we did a Go Team training with Dr. Kundi the other day, State Police and Express Care. And so you said this 25-minute flight, which I trust is accurate. And then, you can't teleport to the helicopter. So we'll give you a really smooth transition. We'll say 10 minutes and we'll say like the OR is ready. You're going right to the OR. So 25, 10, and 5. We're talking 50-ish minutes, best case scenario. Dr. Kundi was talking about trauma patients, and this isn't a trauma patient, though it pretty much is a trauma patient at this part, because it's probably some lacerated pelvic vessel. It's really the only thing that should bleed like this in my mind. And he was saying that full Reboa, and Sam could consult Ann on this one if needed, they only put it up for about 30 minutes. Partial Reboa, the literature is poor at best, but getting there, certainly a possibility in this person. So you're even pushing the limits of Reboa if you were able to get a Reboa catheter and then a Reboa clinician to the bedside. I mean, absolutely, if you're stable on the level 1, it may be something to think about. Call the vascular surgeon to come with the state police and the 140, the AW 139 or whatever, and it's just something to keep in mind. I had the same thoughts as you.
So no, and I think, Jeff, that's a great synopsis. I think that the data on Reboa, as we know, is not showing to be as favorable as we hoped it would be, quite candidly, and in various settings. So it's just a thinking about what are the resources we have. So getting back to what we know concretely, we know that stable on the level 1 means we're just putting the stuff in as fast as it's coming out. That's my formulation. And that's what, Cody, when I hear you say that as the medical director on the other end, that's what I'm hearing. That's what I'm interpreting, is we're just keeping up at this point. So we need to do everything we can to buy us some more time. So with that being said, what are the current blood products we have on hand? How much resources do we have? Because we need to do a quick time calculation to figure out if we even have sufficient stuff to make it through the flight. And that's, I guess, my big, where my brain is going at this point. If all we're going to do is temporize. And then the other question I have for you guys is on the aircraft, for the PHI aircraft, what type of pressure infusing system do you have? Is there a light flow? Is there other things that we can use to manually get blood in fast? Obviously, for the reasons we already agreed, the level 1 isn't going to fit in the back of the aircraft. So
pressure bags are what we have available. We don't have a level 1 or Q and flow or anything like that.
Yeah, so that's an interesting discussion point to maybe follow up with, right? Because pressure bags, I got to tell you, they seem to put pressure everywhere but on the blood, and in my experience. So
Asa, I see you got your hands up. What do you want to add to this discussion before we move on and kind of progress this case?
I am definitely in agreement that Reboa is certainly an option here. Even though we're temporizing, we all said that's a relative term. I think we're going to get ourselves in trouble, even if we're relying on the 1 in versus 1 out methodology of giving blood and it coming out, because you're going to end up in situations where you're going to have some consequences of large volume transfusion ultimately in this patient. So you're going to trade one problem for another problem.
For sure.
So I think we're at the point that we need to do something different. And even though the blood going in is temporizing, you're going to see that there are going to be other problems that are going to develop with that much blood product given that quickly over that short a period of time. And I think this probably would be a good case for a partial Reboa. The time obviously on ground is going to be difficult, especially if you're going to do like a zone 1 Reboa, maybe a zone 3. But again, like if this is a pelvic vessel that's coming high up off of the aorta and maybe just under that renal artery, you may miss it with zone 3 Reboa. So the Reboa is not a slam dunk either. I think if we do it, I'd probably, just to be safe, would do zone 1 and I would do intermittent or partial Reboa.
All right, well, I think we're going to keep going. So Cody, I'll let you keep painting the picture on this case.
All right, so this is what's in place when we walk in. She's getting 2 units of red cells about every 5 to 10 minutes. Of course, she's intubated. She's on a vent, getting about 10 liters a minute ventilation. She's obviously tachycardic. She's pale. Her cap refill is forever. You need a calendar for it. Her MAP is 58, and we've got some good central access and at least an art line to help guide our resuscitation. The blood gas at bedside is as you see it, so she is definitely in a pretty profound metabolic acidosis, and we're obviously attributing this secondary to massive hemorrhage. All right, next. This is a snapshot in time of things are going okay-ish for us. So the thought process that we had, and we'll talk about this in a second, was how can we approximate what the level 1 is doing with what we can do in the aircraft. So we're still thinking this is a possibility. We're gonna have to do some MacGyver stuff, but how can we make this move happen? We're not super crazy about her SpO2, obviously, but she's losing blood as fast as she's getting it. So okay, that noted, we got it. Her end tidal looks like garbage again. cardiac output problems. Her blood pressure and MAP are okay. We're not super excited about it, but we've got MAPs of 76. We got MAPs close to 60, MAPs of 80 in the 90s. All right, let's get things going. So what we thought we could do is we spiked 10 bags on pressure. I'm sorry, 6 bags on pressure, blood pressure cuff infuser device things. We went up, we hung levo, we went with 10 and 4 for levo and epi, and we kept the bicarb infusion going, and we slide her over to the stretcher. And up to this point, we're thinking, okay, we can get this done. We're doing okay. We've talked to, or have I talked to you yet by this point?
Oh, no, you didn't tell me anything good at all. No.
Oh, so no, we haven't got to that part. I didn't tell him anything good. So things look like they're going to be okay. So we slide the patient over to the stretcher, and next slide, please. This is what we did. Excuse me. This is where we're at. 6 units of PRBCs, 10 on levo, 6 of epi at this point. These are our vent settings. Again, I'm thinking we changed those vent settings from what they were to what they are. Essentially, we don't want to overinflate this patient's lung. She's super preload dependent, and we don't want to make things worse by just trying to, pick the ball up and run with it as far as the ventilator goes. So the problem that we have, can't take the level 1, but it is generating the mass that we're seeing. At least that's our theory. So how can I approximate this? So next slide. So that actually is a flawed logic. If you've got normal vessels, normal volume, that may work. If you have normal volume and a constricted vessel, it may still work, but we have no volume and constricted vessels. And so we're not going to see the flow that we want. So there was a flaw in our logic there. Next. So this is where things start to get fun. I believe the phone call to Dr. Launer was made. So we slide the patient over, and things are going bad. The map starts to drop, the end tidal is starting to drop, and our blood pressure, we got a systolic of less than 80. So in our minds, we're going, okay, our patient is now it's peri-arrest. Something is not going right. Something is not going the way we want it to go. So we tried to titrate up on the levo. We left the epi where it was. The sending physician was at the bedside the entire time. We're talking through our strategy. We're talking what we can do. Next slide. And then things really got out of hand. We've called Dr. Launer at this point, and we're trying to talk through options. We're trying to talk through what we can do. We've talked to the CCRU. CCRU is saying, look, we can't really do this with the patient on pressors, so let's try to stabilize until we don't need the pressor support anymore. So we're staying on scene to assist. Our levo is up to 40, epi's up to 10. We're getting 6 units. We got 6 units in over a 15-minute period. Put the blood back up on the level 1. Our blood pressure starts to come back, as you guys can see there, over that 25-minute period. Next slide. So that's the story.
Yeah. I mean, and I think we've all been in some level of this situation where the patient is like, looks good, looks okay in the bed, but as soon as we go and poke them with a stick and try and put them on a stretcher and all of that stuff, like I swear there's like nitro or like some vasodilator on our stretcher that immediately makes patients' blood pressures drop through the floor and heart rates skyrocket and the ventilator starts alarming. Like in every single time you're like, okay, we got them settled in the bed. Now move to the stretcher. Oh shit, now go back to the bed. Like, so my question to the group and is there a way to approximate this sort of 1 in, 1 out? Can we just get all the blood and pressure bag it? And is the vasopressor theory a flawed one? Are we just basically making it making them bleed faster? And to be honest with you, I'd love to hear. We got a couple residents on, so I'd love to hear y'all's thoughts as the ones closest to the academics. They're all hiding in the back.
Who's going to be brave?
I will. I think also, I'm sorry, I'm in the hospital waiting to be taken in for a procedure, so if I have to run, that is why. I think this is a tough spot to be in because we know that the answer for hemorrhagic shock is more blood products and not necessarily vasopressors, because that if you have an open leaky pipe and you're squeezing the pipe, you're just going to bleed out faster. But at the same time, you also need to make sure that the patient's able to perfuse their end organs, and we're not pumping anything into her fast enough for her to be able to do that. So I don't know that there is a right answer. I know this is an unsatisfying, hedgy answer on my end, because it's a bit of a tightrope to walk. I think you kind of need both at this point. You can't let the patient be hypotensive. So I'm not sure that I have a great answer for you, as unsatisfying as that is.
I think that I would just say that's the most satisfying answer ever, because it takes a lot
Yeah.
for us to do that, which we'll go on to later. I'm struck by, even without divulging what's going to happen next, we've got, the ground course and a couple of other things. I think we have to know, when things are so uncontrolled, and saying, I don't know, is a great healthy pause to really rethink what the goals of this transport are and what we were actually doing. Because I think there's also this inertia, right? Once we say, we're going to do this, we're going to make this happen, we have an aircraft at the bedside, we've got all the experts. There is a tendency to kind of, you almost get this like confirmatory bias that we're going to make this happen any way possible. So I would actually applaud you for saying that, because that, I don't know, was a very healthy pause that actually changed kind of the trajectory of this case.
I think this is also a good opportunity to plug EMS training, EMS fellowship training, because the statement they have to be off vasopressors is kind of a silly one for the sake of this discussion. I mean, Dr. Morse just hinted at it. It's like, well, what's the end point? Is sort of what she was saying. And the statement from the receiving facility, who there's only one EMS trained person who works in that unit, they have to be off vasopressors. I mean, that's kind of crazy. I mean, we're talking about just getting them there for definitive hemorrhage control, either by any means necessary or keeping them in the facility. The off of vasopressors is not the point. And they gave you some endpoint that's presumably unreachable at this point, unless you're talking about developing abdominal compartment syndrome, which is challenging to develop with an open abdomen. I mean, it's not going to occur. So they didn't give you a very sound advice. And I think that they've lost perspective on transport, which is, again, a plug for EMS fellowship training.
Eric, what you got?
Hey, two things. One regarding the vasopressor debate. It's interesting, but you would think that at some point those adrenal glands are just done and they're out of catecholamines. So you're going to have to supplement it somehow. That's number one. Number two is, earlier, Cody, you said that they thought she was too unstable to go to CT. I feel like CT is going to give you so much information. And if you can transport the patient 25 minutes in an aircraft, surely you could get to CT, right?
Yeah, fair enough.
Yeah, but we have to take them 25 minutes down the road. They have to take them to CT, and they're more scared than we are.
Well, yeah, and that's where,
guess.
In many ways, Lifeline, and I'm sure Express Care as well, just their presence adds so much faith to the treatment of the patient, adds so much additional assistance because of the excellent critical care training. And so I wonder if we can say, hey, we've got this crew, can we take them to CT if we give you a hand? Because you got to find where the bleeding is coming from, because I don't know what the receiving facility is going to do any differently.
Is there a role for ultrasound, or are you just going to see a bunch of blood in the abdomen? Like,
We can talk about that too. But
okay.
Good point. Good point.
Kosh, what do you got? I see your hand up.
So apologies if I've missed this, but do we know anything about coagulopathy in this patient at baseline? Like, as far as unlikely that there's hemophilia, but any sort of like von Willebrand's disease or anything like that, has that been broached? Because and the other thing is, do we have a fibrinogen level on this patient?
So number one, that's a good question. I'm not aware that we knew of anything about coagulopathy, but I know that there were a lot of DIC labs, which I don't know that we had at the time of the consult. I can say that if there was no coagulopathy, they did a pretty good job of any iatrogenic coagulopathy by the time we were mobilizing. But that is an excellent point. The history is very unrevealing because it was just a witness arrest and we couldn't really ask her anything. So, and there was nothing available in PRIS that I was aware of.
Because I wonder whether or not like empirically giving some desmopressin might not have been helpful, or at this point she probably could use some fibrinogen too, because I know that she did get cryo, or she did not get cryo.
She did. By this time in the conversation, she had gotten 2 units of cryo.
Okay.
I think we're at like 50 products in total by this 1725.
And then she had gotten some factor 7, correct?
Got 10 milligrams.
And was that just plain old factor 7, or was that recombinant activated?
I believe it was recombinant activated.
Okay.
It's a good question. Let me look it up, but you guys keep talking.
Dr. Levy, I see you got your hand up before we move on here.
Yeah, just so actually, Kosh touched on a lot of what I was going to say. Guys, I may have missed it. Did she get TXA already also? And
3 grams.
3. Okay, thank you. Just didn't hear it. And then the only other question I had is there's nothing. So we are in your what's the transport platform? We're in the 135, or just remind me of what our physical space is here.
We are hoping to get into a 135.
Hoping to get to. Okay.
Yeah, I haven't made it.
Okay. All right, and I'll tell you why in a second. I think we've all agreed we're entering heroic circumstances here now, and at some point we have to just consider. Dr. Margolis mentioned it, I mentioned it, Jeff mentioned it. What kind of aortic compression can we apply and maintain to just, if we can't stop bleeding, slow it down long enough to get up the road? So just wondering what our physical options are for that. That's all. Thank you, guys.
Asa?
I'm just curious what others would think about this, but would anybody find a tag helpful in this patient at any point earlier?
I was about to bring up the tag, and all it is going to be the lab's going to draw with a red crayon a line and send you back the tag.
Yeah, anybody find these helpful? Anybody use these to sort of guide the resuscitation strategies when they're doing massive transfusion or multiple blood products? Just want to throw that out there to the group.
Asa, wouldn't you think that we're like 50 or 60 products in at this point? I don't even know what kind of data we would have on. I mean, I agree with you. I was thinking about tag guided as well, but the answer is, should we just be given more TXA, is I guess empirically at this point too. To your following along your same statement with that degree of volume, that short amount of time.
Cody, has general surgery seen the patient? I mean, I know this is like ridiculous, but an obstetrician is unlikely to ligate a pelvic vessel, unlikely to clamp an aorta, unlikely to clamp an IVC. A C-section XLAP is different from a true XLAP, unless they, made a cross sort of situation. Although there was perimortem C-section, so probably a big vertical incision in the ED anyway. But what?
If I remember correctly, so yes, I think to directly answer your question, yes, she had been seen. And if I remember correctly, the sending physician was a surgical trained, / critical care physician.
Didn't they even do IR? There was an attempt to get this woman to the IR lab.
There was an attempt for IR as well.
I mean, they did a lot.
Yeah, if I remember correctly. Yeah, but I do have a question. When we were talking about TXA, so normally in the pre-hospital world, you're capped at 2 grams, and that's enough. But with the amount of blood that this patient has gotten, it's safe to assume that TXA is sitting in her belly somewhere. And should there be consideration to redose or to re-administer TXA at a certain point?
I wonder what the utility of it is at all, just theoretically, because she's replaced her blood volume so many times over. And how long
that was kind of my point as well, guys. Cody, I agree with you. It's not where we want it to be, right? But is it? Or we're fighting multiple different losing fronts here on this battle. So yeah.
I mean, at this point, this is fairly ridiculous, but we're in the ridiculous territory. What about just cross clamping the abdominal aorta?
Just wrote that.
let's,
Good
Kosh,
question.
I think we might get to that discussion a little further in. Let's keep moving on the case. And Cody, I'll let you, we've sort of talked a lot about this, sort of the, do we just snatch her up and go and hope for the best type of thing? But the problem was every time you slid her over, right, she'd parry arrest or arrest, and nobody, that's not good, right? And it's too far. And of course, I don't know where you were, Cody, but I'm gonna, just because of this is Murphy's Law, guaranteed you were at a remote LZ. Like
1,000% there's a remote LZ. And
so you were gonna have to make 2 stretcher moves at this point, and this is gonna happen in a field somewhere. And so I'm sure that factored into the thought process as well.
yeah, that's kind of where I'm getting at. Like, hey, God, it's me again. We're gonna need to chat 1 more or 2 more times before we get this patient to the CCRU. And so, yeah, that's kind of where we're at, of like, all right, nothing's working. We can try the jet fuel infusion and just try to get her there. But our concern was that we're just gonna kill her, just move her. That's our concern at this point. And she's initially responsive to volume pressors. And our conversation with Dr. Launer and the rest of the physicians was, if we can keep the massive transfusion going and keep vital signs supported until arrival, then we can basically take a hopeless situation and make it a bad one. The situation, though, what we came to understand, collectively between, my partner and I and Dr. Launer, was like, listen, it's not beyond our skill, it's beyond our resource, what we can do. There needs to be a person, so the ventilator is acting up at this point as well. We're getting pressure overshoots, constant pressure overshoots, to the point that now there was a little bit of intermingling of the sending staff and the doing their thing, and then us trying to do our thing, get ready for transport. So she had actually been popped off the ventilator and was being bagged by the sending physician at one point on high peak. With this conversation for another day there. But the kicker is the blood, the lab is running out of red cells for us. The Red Cross is apparently en route with some more blood products. And we're like, well, we can't wait for this. How much longer can we're about to run out of blood. And what, this is, thanks God, you weren't listening. There's another problem here that we didn't need. Next slide. So thoughts.
Eric, what you got? I see your hand up.
It's just the more we get into this, the more just incredible this case is, and just an incredible job by the crews. I was wondering, at any point, was there a group conversation between the referring facility, the receiving facility, and the transport team to say, like, what is our goal here? Because it sounds like the receiving facility said you got to get them off pressors, but so that tells me like there's maybe not a real good, like, heroic plan to save this lady. I was trying to understand, like, what when she gets moved, what else do they plan on doing for her that would warrant such a high risk move?
Yeah, good question. I think we had 3, at least we documented 3 big discussions. I mean, there was probably 10 phone calls made, but 3 discussions to that point of like, listen, we're probably going to kill her just moving her. And what's the end goal here? How can we still, what's the right decision? And the right decision was definitely made at that point, was definitely do not try to put this patient inside a helicopter at this point. She will not survive that transport. I hope that
to me, this brings up, and Cody, I know you and I have talked about this. This brings up a more philosophical question for me, and take this case as sort of a jumping off point. But beyond that, is there such a thing as too unstable for transport?
Yes.
I've been told before, like, this patient's too unstable to transport, and I would agree that this patient meets that criteria. But my question to the group is, where's that line exist? But where is that line? I mean, apparently we found it with this patient, right? This patient crossed that line.
Well,
So-
not yet. We
Well,
to be continued, man. We all these questions which we talked about. We just crossed the line of the 135 stretcher. But yeah.
yes, they crossed the line for the 135. So, but my question is like more of a global philosophical one: is too unstable for transport a thing?
I think it's relative. On the Eastern Shore in a freestanding ED with no blood products, the option is dead or transport and
Sure.
may die in flight. So you take that choice. So there's no such thing in that scenario. In a place with general surgery, obstetrics, IR, that once previously had upwards of 150 products, I'd say there probably potentially is something that's too unstable for transport. So it's a move, the goalpost moves based on what's available. I used to work in freestanding in the middle of Western Pennsylvania. We had 6 units of product. After 6, I don't cross clamp aortas. I don't cut abdomens. Gotta go.
Yep. Fair enough. Asa, what are your thoughts on that?
I would agree with Jeff. Although, we often find ourselves in a situation when they call, they've exceeded their capacity or their resources. And the question becomes, is the patient, too sick to move, or they're really actually too sick to stay where they are? So, before we say they're too sick, you got to think about what that other option is. And that other option is often death, which may be the option if we transport them, but it'll surely be the option if they stay where they are.
It seems like the
Ruben?
Kobe question of,
Yeah.
okay, the patient dies here, or they die in the helicopter, or where we deliver them to the receiving facility where they're probably going to die there too.
Ruben, you've been quiet on this. What are your
Yeah,
thoughts?
I think everybody is asking the same question. What exactly are we offering this patient when they arrive? So I think that's the $1 million question. And if there's something additional that we can provide, then 100%, there's no such thing as a patient too sick, because we're going to get them there. At least we're going to give them their best shot. But I still haven't heard what exactly we're planning on doing for this patient when they get here.
Well, it is the intergalactic trauma center of the universe. So they have things that nobody else has, right?
Clearly.
All right. Well, I think
with
we'll
all
keep,
this blood product that the
Go ahead.
patient's been getting, and the fact that she's basically leaking out everything that she's being given, was there ever a use of, and I mean, transporting this would be not feasible at all, but was there a cell saver employed at all to maybe try to do a pseudo auto transfusion because it's no longer her blood that she's leaking?
Mhm.
No, sir.
where do you pull that from, though, Kosh? Like, are we tapping our abdomen?
The remote.
Well, I
is-
mean, what I guess suction.
Good thought. And we'll talk about this. We can talk about this later. We'll keep moving. I have something that I'd be interested to hear everybody's thoughts on. So Cody, keep painting the case for us here.
So it's one of those situations like, and you'll hear me say this again of, just to rescue the princess, you don't necessarily have to kill the dragon to do it. So the patient definitely cannot stay where they are. They are beyond what that sending facility can provide. Air is faster, but it's not feasible. And the mission, or the next stage in this patient's care, is to transport. That doesn't necessarily mean fly, but this is enter Dr. Lahner and the final solution.
Yeah, I wish I had one. So so this leads into the ground transport arm, but I just want to say that I totally appreciate all this discussion, because there's no good answer. And so Cody was calling, the CCRU was calling, as Jeff mentioned, there's all this stuff about we need to be off of vasopressors. So it's very difficult to get involved. And as Jeff Nussbaum will attest, University of Maryland, and Sam, you know this, we have the most complicated pathway for any type of acceptance, right? So by the time I got involved, there must have been, and I don't want to exaggerate, probably 87 people, involved, multiple consults, none of which are actually at the bedside. So by the time I got the call, it was clear to me that there were multiple conversations going on. And to your point, this conversation that we're having right here talks about, should we even transport? Are they too unstable? So the first thing I did is I told the CCRU to please stop calling. And I went up there physically. I was in-house and we had a conversation. One of the things about EMS fellowship is we really had a hard stop, and we kind of conducted this just-in-time incident command option. And I put this to Cody, to his credit. I said, just let me, these things were still developing. I said, can you accomplish the mission? And he said, no, man, I'm not going off that ledge, dude. It's not going to happen. So we knew that the 135 was not going to happen, at which point I called Ace. I said, can you get your heroic 145 and rappel down with the Secret Service? He said no. So then I went up to the I went up to the CCRU and I said, listen, we need to have a conversation about what it is we're doing. So number one, to your point, what do we have to offer? Now, at this point, this hospital was running out of blood. So they were going to just have this patient expire because they had no blood products. And as you saw, they were maintaining a map by at least infusing. So one issue was, if we didn't get there with blood, if we didn't figure out blood, the patient was going to die until we worked something out. So one solution was, how do we solve the blood issue? So in terms of thinking laterally, and I'm just going to set the stage because I think there's so much transport medical decision-making here, but we did get the American Red Cross to dump off something. I had never seen this before, but it was like I don't know, several 100-gallon cooler that we could put into the truck that you see there. So ARC was there. We actually emptied out the CCRU fridge, which anybody that knows UMC transfusion medicine knows that was another act of God, who, by the way, was not on call because he or she wasn't paid. So we did figure out the blood issue. Number two is, what are we going to offer this person? And to your point, in a person, it sounded like she was developing DIC. She was bleeding from everywhere. There's blood coming out of the pelvis. We didn't think that going into her abdomen and having the person cross-clamp the aorta was going to solve anything, because it wasn't very clear where the bleeding was coming from, and she had already been to the OR. Plus, as Cody mentioned, it was a surgeon that was trained as the intensivist. So we had decided, and again, I can't defend this plan, but the rationale was so it sounded like she was peri-arrest moribund. However, the consensus from everybody on was, we were not going to let this person die because we were going to run out of blood. And we all were very clear what the risks were. We were very clear that we were going to make her a DNR in transport because there was no endpoint. We were very clear that we were willing to take the risk for the purpose of getting her to the STC, where they would have the intraoperative CT, they would think about AR, and they were going to do a damage control XLAB. So we had concocted a plan to send there was myself, there was a cardiothoracic intensivist, there was the transport nurse, and we took Sam Galvagno. So we brought a whole team, and who knows, once we took Sam, we figured we could have just gone with him. But I want to say that this became a very interesting sort of mini exercise in incident command. So if you can imagine, we get into the ICU of this hospital, the room is 85 degrees. There are 20 people in this room with blood all over the floor. There must have been, I don't know how many IV poles. There was no room to touch anything. The woman was just, I mean, she was literally hemorrhaging to death out of all sorts of orifices. So we decided, if the goal is to transport her and to maintain blood, we're going to divide up roles and fix the mission. So we tasked every one of those people with a specific task. So number one was ventilator management. So the other was transfusion management. The other was an attempt at Reboa. And the other one, and I'll never forget, this was Tori's a couple of shifts off of rotation, and she was managing the whole thing. We had to have somebody that was actually looking at the resuscitation, because as anybody can attest in these situations, there are so many alarm bells. There are so many things going wrong. In addition to the vital sign monitors going off, the overpressure alarms in the Hamilton, the continued hemorrhage, operating the ultrasound, it was an absolute mess. So we did assign, we had a plan for extricating this woman, which was successful. And you can go on to the next slide. Unfortunately, the transport course was complicated by continued vasopressor dependence, and we had a lot of trouble ventilating her. And I think, I believe you had all mentioned this, that she had received so many blood products that I'm sure her lungs were just completely distended or hampered by the development of at least trolley or taco, because the pressures that were required to ventilate this woman were huge. I was getting the end tidal alarm, so we had to adjust the pressure monitors on the vent, and eventually we were able to troubleshoot that. Sam was doing the level one, our version of a level one, which is a pressure bag en route. And then we had the attempts at Reboa, which, because she was unfortunately morbidly obese with an open abdomen, the utility of ultrasound was just not there. Ultrasound could not see anything because of, I think it was also the open abdomen, the gas, and the morbid obesity was just very difficult. So we maintained that en route, and the transport course, we were able to transport this woman with the purposes of getting her to the Intergalactic Shock Trauma Center of Excellence to temporize the bleed. So if you go ahead, we can talk about the STC transport course. And I will say, she was able to maintain a pressure, and they were able to see on the XLAP, the ovarian pedicles from the ovarian hysterectomy were just continuing to hemorrhage. They could not oxygenate her due to the taco. She had several rearrests. They attempted VV ECMO to troubleshoot, and she died, to your point, quite literally, I think the night, that night of. She was rather sick. And I think this really begs the question, and I don't want to shape the panel course prematurely, but it's not about unstable to transport. It's about what are the goals of care? What can we accomplish in transport? How do we think a little bit laterally or outside the box? And another fascinating thing that I think I found particularly challenging is how do you troubleshoot in the midst of information and clinical overload? I mean, this woman had multiple problems that were not only single system, but intersecting during the transport. So yes, it was a victory in terms of getting her there. And you know, I would love to talk about the medicine. I think the logistics are very important in this case because we were able, once we engaged medical direction, once we engaged the flight crew and the CCRU and we're all on the same page, we were able to eliminate all of the absurd plans. I remember one plan with this was the helicopter was going to fly, they were going to intersect with the ground crew, we were going to do an intercept, we were going to send an ambulance down there, and we said, no, we're just not going to fly this woman. And if we do this, we're going to take our ambulance down there with a cooler, with resources, avoid the multiple loads and offloads, and then try. So
I forgot about that.
yeah, that was a good one. Yeah, that was a good one. Where we were going to meet this woman on I-95. So that I think is the utility of the medical command aspect, but certainly rife with a lot of things to discuss. So that was her clinical course at shock trauma.
So just to sort of review, like Cody, you threw this in here, and this is sort of what we think, sort of a review of what happened. Is that sort of what you were getting at here? Like this massive inflammatory load just caused her to, essentially she went into DIC. Is that the overarching thought of like what was her final demise?
Yeah, and my kind of my point behind putting this slide in here is if you change the context just a little bit and that lady had been hit by a truck, they look exactly the same.
Sure.
Right. This is a blunt, this looks exactly like a blunt traumatic arrest patient. The inflammation load just from the trauma of getting hit by a vehicle. She had already been in cardiac arrest. She'd had a radical hysterectomy. I mean, so there's a huge inflammation load, which is leading to, and I don't know if it's, I think we talk about it here in a minute, but to be considered, if it's too fringe to talk about things like endotheliopathy and how that's complicating the picture, and how you can give that patient, I think it was mentioned she had no catecholamine left, and we could be dumping all the pressure in the universe on there, but maybe her vasculature has no capability to constrict at that point. And then obviously severe coagulopathy, and that's what I was thinking of the entire time we're there. I'm like, this patient has been transfused about 3, 4, 5 times her blood volume. Yes, she is coagulopathic, and she's probably a little cold to begin to go along with all of that. So this in my opinion, this is the situation there. These were the 3 problems that we were having to deal with, and in isolation, they could independently, each one of these things could have killed this patient, and all 3 of them all at once certainly made for a sporty transport event.
I said endotheliopathy at least 5 times because I was trying to figure out how I would consult that. So you heard it here first. I don't think that's ever been used on the Baltimore Critical Care Collaborative. We're going to create a protocol for that and then not share it with you guys. It's that endotheliopathy. We have a fellow actually that trains in endotheliopathy at shock trauma. We have a service probably too. But I think, Cody, I'm so glad you mentioned that because and Jeff knows, like we had to write a protocol that says there is no protocol for unstable to transport because we do this all the time. And I'm sure disappoint Asa if I said we have a hard line, but I do think that I am still, in retrospect, the call very much bothers me because I think all of us knew that at the point with which we decided to concoct this quote unquote heroic transport plan, the outcome was going to be sealed. And really another question, which may be beyond the scope of this esteemed group is, at what point should we say, look, if she doesn't survive or if she doesn't turn the corner with XYZ, when I talked to one of the CCRU physicians, that's what he was trying to get at with the must be off pressors. I think we knew that there was an almost certain likelihood of demise in this case. And so the question was, can we reach a threshold with which we say, you know what, it's really not appropriate to consider transport. But I think all of you can also appreciate that when you have a 30-something-year-old mother, who is dying because of a potentially reversible hemorrhage, the overarching bias is to do it. But I do think that's worthy of discussion. It's very difficult.
Well, and to add to that, Dr. Nussbaum kind of hit on this a little bit early on in the introduction, is that, losing babies in the OB world is tough. Losing mothers in the OB world is tough, but we were being watched the entire time by a father who had just lost his new son and was losing his wife at the same time. And it was heavily coloring the emotional piece of our decision making. It was very hard to stay detached knowing that was happening. And obviously, to her credit, she was sticking with it. And the senior physician was in a pretty tough loop there.
Yeah.
And she'd even gone back and forth a couple of times, like, you know what, never mind. You're right. This is hopeless. And then a consult later, it's like, never mind, we're back on. We're going to do it again. So yeah, that's a good point.
I think the ability to say no to and justify your decision, I know that's not in your wheelhouse a lot, but I think that was very telling to be able to say, look, before we do this, I need to know, can you put her in the helicopter? And it's not about can we, it's that we are not going to do it because it's not going to help. And sometimes I think we need to stick by those decisions and try to make those detached discussions and detached sort of syntheses happen. And it's hard to do when you're in the midst of this, in a way that is even informed by evidence.
I think a point that Ben mentioned in a different context, first of all, I need to say the word ASV so I get it in there. So ASV is now said. So moving back to my point, Ben mentioned that the room is 85 degrees and he was mentioning that for his own discomfort. And the comment was that Ben was sweating, and we all feel thoughts and prayers to Ben's sweat glands. But I think hypothermia is underappreciated. I mean, there's the lethal triad of coagulopathy that I think is turning into a square, rhombus, or pentagon. We're adding things. I don't know what the latest and greatest, what shape we're up to. But all kidding aside, temperature management on the ground, I don't think we do an awesome job at this. Not Express Care, I think we EMS in general. In the aircraft, you do one thing: you wrap them in the marathon blanket, and then you wrap them in whatever warmest blanket you have. And we say, well, we've done what we can. But when I used to fly with Stat, it's cold. It's really, really cold. We heat the aircrafts, but they live outside. They live outside and they're cold. And then the pilots sit there cold, not running, because this person's been inside for an hour. I mean, their shock, their hemorrhage is going to get worse. And I think this is just a reminder that hypothermia is very, very bad. And sometimes actually cranking up the temperature is the right thing to do. And it probably is helpful. And I'm not suggesting we put hot packs on people, but I am suggesting that, sometimes on the ground, we don't do the same things they do in the aircraft. And except that you need to probably access every part of this person, they need to be wrapped up. The EVO needs to be sitting outside with the back of the ambulance at 90 degrees. This needs to be a burn unit, essentially, in terms of insensate losses. And not a criticism, just a comment on something I think we overlook because we're doing other things, but it's still important.
I would add to that some sort of fluid warmer device, whatever that is. If you have it, it needs to be on a warming device, because controlling the environment alone is not going to stop hypothermia as we're alluding to, because this was in July. This was in July, and we all know that the studies that have come from the conflicts in Iraq and Afghanistan show that 90% of those patients are still showing up hypothermic despite getting hit in 110-degree weather. So yeah, I would recommend some sort of warming device.
And I think that's something, to Jeff's point, that we are now sort of just coming around to, both because I think that it was another piece of equipment that everybody needed to get, but also I think the technology is just sort of now starting to catch up with the warmers. I know that the Thermal Angel and the warmers that I had when I first started in this business, we've basically proven that they were doing nothing but taking the edge off. They weren't actually warming the fluid because we were giving it so fast. They just couldn't keep up. And luckily, it seems like now we've got some devices out there that seem to maybe not be perfect, but they're a lot better. I think that definitely is a key thing, is avoiding that hypothermia. And I think this is this very similar situation to the protocols for calling it in the field. right? Like this is a situation where it's like, why, like, what is the end goal? This is a much more complicated, much more nuanced decision, but it falls in that same vein of like, there are certain situations where moving the patient, while we might be able to do it, just because you can doesn't mean you should type of situation. And so I think it's a very interesting conversation, and it's that it goes back to me, for me, to the too unstable to transport. And I pride myself, because I guess I'm a type A competitive person, is me against the patient, and I'm not going to let them win. But sometimes not letting them win is the wrong answer. And we should give some people, like, you're just doing it because you want to do it, and not necessarily because it's what's right for the patient. So I think this is a situation that every critical care transport clinician needs to think about being in this situation, and how they're going to respond to it, and how they're going to take that pause and go, but what's the end point? What is our goal? What are we doing this? Why are we doing this?
Well said.
And to build off of that, there's also the consideration that needs to be made for, with a patient that's this sick and with the goals of care and the outcome is unclear, the interventions that are going to happen are unclear. We have to think about not only the patient, but also the safety of our crew during transport, the safety of the general public during that transport, because those are all things that are going to be affected as well. And that has downstream consequences.
You know, when you think about an arrest in flight, I think about the effectiveness of compressions, because that's the only thing that's going to keep a patient alive. And can you do compressions in aircraft? Sure, you sure can. Are they as effective as they would have been otherwise? No.
My question to you is, do you treat this patient almost like a traumatic arrest? And like, are compressions the right answer, or all you're doing is pumping the blood out faster at that point?
That's why we talked about TNR for the transport too. There was a lot of discussion that, if the patient arrested, we're not going to open the chest in the aircraft. And, yes, you can compress, but I think it was also very clear that if she were to arrest during transport, then that was going to be the end. We did set some guardrails. So yeah, we did talk about that, and that was also just a no-go.
Yeah. Do any of the folks that are joining us, I know we've talked a lot to the panelists, but anybody that wants to unmute, hop on, ask any questions. This was an extremely complicated case, and I'd be interested if anybody's got any questions that we haven't asked already.
Hi, good day. I'm calling from the Virgin Islands, and this was an amazing case. The medicine was incredible. My name is Robin Ellett. I'm medical director of the USVI's fire and EMS system, and I'm new to it, and I'm just so pleased and thankful that you all have me here to hear this case. But it was really amazing. The medicine alone was amazing. The job you did was amazing, and it would have never happened here. So it's just had my eyes open so wide at certain points, where I realized we would have said this is futile earlier, much earlier, for resources, and we just wouldn't have had as much blood as you poured into her. So I commend you on your effort, and I really commend you on talking about this, because there's so many take-home points to learn from it. And I've learned a lot, even though this isn't something that we would ever be a part of. Thank you.
Just for my own benefit here, I know I can speak for Sam and Asa. Part of the reason why this was incepted is to share these key points. So thank you so much for attending, because we don't want to make it so that, this is the way we do medicine necessarily over here. I totally appreciate the fact that there are key points. You'll find that the other cases are not quite so extreme, but I think every case we do, we really try to have these lessons, because this issue of too unstable, this issue of logistics, this issue of, how do you prioritize is so important. So thank you for those comments. That's good to hear that there's at least some utility. This reminds me of another case too, where we had a transplant patient that was very sick, and we enlisted, I think, the help of STAT at that time to have 3 helicopters and we had an intensivist run out with the Aerogen to give, EPO. And I think that we don't think about the goals of transport enough. I think anytime we undertake risk, to Cash's point, anytime we are saying we're going to put these machines in the air, put these machines on the ground, put everybody in a moving box and expose themselves to not only physical harm, but risk, there should be that risk synthesis, because this is an extreme case for sure. But as we just heard, I think these discussions are very important to have, because I think there's risk in everything that we do. And if it's not for an outcome that may be achievable, I think that deserves, some consideration, or at least a healthy pause before we accept. Be interested to hear if anybody thinks this case was futile. Like, would you have said this is futile earlier? Based upon, Cody said, look, man, I'm not gonna be talked off that ledge, but would anybody have thought that this case would be futile earlier in terms of, why would you have even deployed those resources? I think it's a very important question.
I honestly don't think that at that time, right? You were so deeply involved in the case, from a resuscitation standpoint, from, as Sam said, a competitive standpoint, from, that somebody just lost their child and now is about to lose their wife standpoint, that it is very difficult to step back far enough to be able to see that far down the road. And I think we're talking about it now and looking and saying, wow, they got all this product and look at their pH, and we sort of expected them to develop trolley and taco, and we expected them to be in DIC. So what did we expect the outcome to be? I just think it's a very difficult ask to have of yourself and of your team in the middle of a resuscitation that at some points seems like it's going okay, and then it doesn't, and then you gain a little bit of ground, and then you don't. So that, I think, just adds to the complexity of it. Not simple by any means, nor would I expect anyone to be able to say clearly, you know what, I think this is futile, let's not pursue.
So maybe
I just want to say one more thing. Excuse me. I can't raise my hand because I don't really know how, but this is Dr. Ellett again. I was the first person to use that word futile. You guys didn't use it at all. And I like the way you went at it. I don't know. I hope I didn't bring that to the table, because that's not what my comment was.
No, not at all.
No, very important.
Not at all.
I think the question,
this was excellent.
I think the question may not be, or maybe the mindset is not too sick to transport, but not too sick to try, perhaps.
Yeah.
Asa, I'm going to push back a little bit on your statement. I mean, I completely agree when you're into the weeds of it. Like, Cody has no choice. He's doing it. He's in it. The physician there has no choice, but someone probably has to make the choice. And maybe that's the EMS medical director who's consulted. Maybe it's ethics. Maybe it's we have a PAO, the physician administrative officer. We are in different times. We're not practicing in the Virgin Islands here, but we are practicing in a time that's different, where blood is limited, where resources are limited. As a thought exercise, someone needs to be the arbiter of, is this feasible? Is this wasteful? And obviously, I love this. I'm with Sam. It's me versus physiology, and I'm going to win. But this patient had an asystolic out of hospital arrest. So the mortality of that is single digits at best, then complicated by a perimortem C-section, with, again, the mortality being abysmal. So we have two things with absolutely abysmal mortality before we add multiple other arrests, multiple disease processes with near 100% mortality. I would argue that by the time Cody said we can't do this, the mortality was 99.99999% mathematically. So, as a thought exercise, I wonder whose job it is.
So Jeff, I'm so glad you mentioned that, Jeff, because at the time I got involved, and I think there's a lesson here for EMS medical directors. We should own that and be the arbiter. And to be very clear, I own a lot of that. When I went to bring everybody together, there was actually a suggestion to convene another committee. Maybe we should talk to ethics. Maybe we should call the PAO. There were 3 more consults to do. They wanted to get high-risk maternal fetal. And I said, absolutely not. We need to make this decision. And if I recall correctly, at that same time, when I was trying not to talk Cody off the ledge, the surgeon called me back with the blood gas and a pressure. And I'm like, son of a bitch, you know, like, so, and the issue is really, can we get blood products? And I said, well, we can't get the blood products there. And then the Red Cross went ahead and said, hey, I just got this cooler. So I do own some of that. And I tried to set some of those guardrails, but not only was the patient rallying at that point, I think we set very clear endpoints. And for whatever reason, it evolved in that time. And I totally appreciate the fact that I think we can at least bring those things to a conclusion, which I think is another lesson of this case, is really involving quote unquote transport experts to at least ask the correct question. We may get the incorrect answer, you know, and there's still a lot of uncertainties about this case that we probably will never know. But I absolutely think that those are important questions to ask whenever we embark on this resource intensive mission, especially against the dragon physiologic demons that Cody talks about.
My question that just keeps popping in my mind is, are we missing a key piece of equipment on the market of being able to rapidly infuse somebody in our environment? Like, I have to think back, and I don't remember, and I'm sure it's old and broken, and I'm sure we can't get tubing for it, but something I had in the military was this little like cassette thing that just rocked back and forth, and it was a rapid infuser of some sort. I don't know how fast it was, but I'd be curious if there's not something. Is anybody aware of anything that's on the market that will do a couple 100 mLs a minute?
Yeah. The life flow is out there, right? I mean, it's really made a case in pediatrics, but there can be a role for it here as well. The question is, you know, do you have the hands to use it, right? That's the trade-off versus putting on a pressure bag, inflating the pressure bag and letting it go. You know, the argument on the other side is like, well, that's probably the most important thing for the patient at the moment. So there better be hands dedicated to the life flow. Again, it's all about the resources you have.
Yeah, and as we saw, like we got a lot of blood in this, and you know, we have to also remind our clinicians and our physicians that I don't know if this is an issue of equipment, because with 18 gauges and cortices, like I think we can get quite a lot of volume. The challenge we had here is whether it's not just about the volume. I think as we saw, it's about her vessels, and it's about, you know, all of the other inflammatory cascades unraveling. So I thought we did a good job. And if I recall correctly, we infused a crap ton with pressure infusers and a crap ton of stuff through the 18 gauge and large bore IVs. I just think we were up against other physiologic mountains that couldn't be negotiated. But you're right. I mean, one issue is rate. I don't know if that's the whole discussion in this particular case.
It would have made the numbers better, but maybe not necessarily make the patient better.
I don't know that it finishes your end, like it makes your endpoint any different, but I would just be curious if something, looking at the life flow real fast, it looks like it'll do 250 a minute is what they're claiming. And that comes down to how fast you can squeeze the gun. Yeah, I mean, I'd be curious if I know the level 1 won't fit in an aircraft, but the Belmont rapid infuser should, if I remember right. It's got a small enough footprint. I know that's what we use in the military, and that thing, I could put that in a 135. Granted, I don't have to anymore because I have a 145.
You can't put it in a 135. No, we need Sam. Trying so hard.
Just a little dig there. That's all.
If I can ask one, or if I can comment, I guess, on one thing about the previous question about who makes a decision when to say it's futile. I don't really know if that's our decision. Our decision is really facilitating the transport, right? And it's the accepting facility who's basically said, hey, you know, we can offer this person something. And I don't know if that discussion whenever was clear in this case, but I don't know if it's up to me over the phone. If Sam calls me and says, hey, I've dumped, 20 units of blood and this and that in the patient, I don't know if it's my call to be like, you know what, stop right there. We're done. This is futile. The accepting facility has offered this patient something, and I feel like it's our job to kind of facilitate that. I think we can facilitate the conversation if it, obviously in this case, But I don't know how hard I'm gonna push the accepting facility to say, hey, you know, I'm not transporting this patient because I think it's futile. I don't know if that's our role, at least in this case.
I put in the chat, but I really love these differences of opinions. I mean, it makes for a really good discussion. So this is great. Thank you, everybody.
I mean, Ruben, I would want your help to have that discussion. I think that is the role of the EMS medical director, is to help facilitate that discussion, because I am standing there talking to a physician in the room that, to Cody's point, is so far in the weeds and just wants to make it better for this father who just lost the son and now is about to lose the wife. And you've got a receiving team that says, just get them here and we'll figure it out when they get here. And I think that I have to somewhat agree with Ben, as difficult that is for me to say out loud, but I have to agree with Ben that, like, the EMS medical director is the person, they're the arbitrator to be the go-between, or to be the one that's disconnected from the situation, because we're all in it and you're outside, sort of a outside perspective. So I'd be interested what the other docs have to say about that, because I 100% agree with your point, Ruben, is like, that's not your place, I guess, right? Like
It's just a lot of these cases are beyond, again, it's similar to emergency medicine, where we're very good at stabilizing things, but we're not the expert in terms of definitive care, right? Yeah. So if you know, a gynecologist or obstetrician says, hey, you know, I want this patient here, you know, I can ask maybe one time, are you sure? Like, do we have an intervention that we're going to offer this patient? But I don't think, now I'm just wasting time if, you know, like Dr. Lana was saying, like, I'm not going to have 8 million different conversations about, you know, the ethics of bringing this patient here and, you know, killing more time. So yeah, I think I will bring up the question 100%, you know, but I don't think I'm going to push back much, right? Once they tell me, hey, we're going, and all right, then let's try it.
That's the mission. Clarification here is that I think you're absolutely right, and I don't pretend to be the ultimate arbiter, but you know, we have a very good handle on risk benefits. And just to be clear, in this case, what was very unique is I was able to actually be right in front of those physicians that were making those decisions, because I think sometimes if we're a little bit remote, you're right, it's not up for me to say, you know what, I don't think this is feasible. I would just simply state that decision was informed by talking with the receiving physicians. And I think once you bring people with that level of expertise together and you talk about what's probable, we have a very different situation than, look, this is possible, I don't know why they don't want to do it. So it was just a little bit more nuanced because of the particulars of this case. But I'm sorry, Cody, you had something else to say.
And I forgot what I was going to say.
Damn it. He's like, I was so glad, man. What in the world?
In this case, I only showed you guys vital signs and clinical course up to 1725, but that's just when we transferred care back over to the ICU. So as the transport team, where we said, you know, listen, we can't move, or we shouldn't, that is really, we shouldn't move. What we did, we were there for another hour trying to help the sending physician and the rest of the folks facilitate, you know, some kind of solution, because.
But where were you when I got there?
I had actually kicked rocks because I knew you were coming. So in your hyperspeed ground vehicle. But yeah, I think I touched on this at the end of this, is like, listen, so maybe your aircraft can't be used to facilitate this transport, but you do at that bedside offer that sending physician transport expertise, and that kind of help, you know, support or color and provide context for some of these things. So that's something I wanted to pass on to all the, you know, all the flight crews and ground crews that are on this call. Like, okay, we can't do this does not mean get in the car and drive home. It's sit there and try to help facilitate another solution, generate that third option.
Yeah, I mean, I think that's extremely important, Cody. And like, I'm really glad you brought that up, because it's a situation of like, don't just say, well, we can't do it, see you, like, good luck. And I've heard of stories about crews walking in and going, well, they're on nitric oxide, we can't help, bye, and just like popping smoke and leaving. And like I think people underestimate the level of calm that a flight crew can bring to a situation. I wanted to do a study one time where we just dressed up lay people in flight suits and sent them into like chaotic situations and have people rate the drop in anxiety, because it's funny like how often I see the air sort of change in the room when the transport team shows up, whether it's a flight crew or ground transport team. Like that outlying facility, if they've been fighting with this patient for a couple hours, they're just so thrilled that somebody else is there.
They're so relieved.
Yes.
They're so relieved they leave the room. They're gone.
Exactly. Sometimes they do. Sometimes they get so relieved they disappear. It's like turn on the lights and the cockroaches scatter type of thing. So no, I think that's an extremely important point. And the other thing that I think is an interesting discussion, and it is complicated by all of our situations in the vendor relationships and everything that we've got differences between air and ground, is like there was not an ability for you to stay with that patient. Like there was, you could not continue that transport by ground. And that's an interesting discussion to have, probably not for today, but it's an interesting thing that I would challenge both our transport teams to think about, sort of from a medical director leadership standpoint. How do we facilitate that flight team then transitioning to a ground ambulance, or vice versa? You upgrade from ground to air, and how do we facilitate sort of that continuum of continuity of care, I guess is what I'm getting at.
And to your point, Sam, it's not that any of the programs that are on this call have a lack of resources. I think it's and in some cases a lack of resourcefulness to recognize that, okay, look, I maybe I need to get ground moving toward this because it sounds disgustingly sick, or whatever. So it's having the forethought and resourcefulness to go, okay, these are the other options I have available. And that's what I mean by, just because you got to rescue the princess doesn't mean you got to kill the dragon to do it.
You see, this is the Cody's Book of Medical Control. We've got a couple of good axioms there too.
I think I know we're weighing on this point, but I think it's just so important. The trends of medicine swing back and forth. So at UPMC stat, we were experts at transporting corpses. We were experts at, the crews would call and it's like, well, they always, because it's so protocol, they need a goal. So the first call on this case would have been, what's our target map? And as I was MD 32 and 21 and 20 over my 3 years there, I would have just fallen off of my chair and just picked my favorite number. Say 80 for the post arrest, say 50 for the don't pop the clot, say 65 because we don't know the answer. So, but we were experts at transporting corpses to die. So UPMC instituted mandatory palliative care consults for people who they use the SafeNet score. So this is a learning point. SafeNet's like a bedside nursing scoring tool to decide who has a reasonable chance of benefiting from the transfer. And we stopped transporting people, and families loved it. Their family members stayed at home. This does not apply to this case. This is wildly different. Now at Maryland, it has just occurred to them that they also should do this because our hospital score will go down because people keep dying because we transport them to die at our facility. And so this is no one goes into 911 to do long-term care, yet every 911 agency and their cousin is now looking into community paramedicine and mobile integrated health. No one goes into flight medicine to do palliative care, end-of-life care, but now the trend is going to be that y'all are facilitating palliative care consults because it's the right thing to do, because we don't have the resources, we don't have the time, because it's not moral to transport people who are at the end of physiology for the sake of nothing. And again, this case is not that. This is not that, but it is the trend. And I wouldn't say you all need to attend a palliative care fellowship with me, but you think looking 5-10 years down the road, you're going to come with an iPad and you're going to call someone and say, wow, ma'am, sir, you are ill. I think we're going to help you be comfortable. And that's going to be great.
Jeff, your ability to pick the future. I will say before you were onboarded, I did have a call from a certain CCRU attending who said, can we transport a hospice patient on ECMO for that same reason? Yes, that was a question. The answer is no.
Yeah. No, I, over the course of my career, a handful of times have gotten to an outlying facility and said, like, what's the point? And we have facilitated that discussion with the family of like, do you really want to drive to the other side of the bridge to the city that you hate and have to deal with parking and have to deal with all of that on top of having to deal with the fact that you're going to have to go up and make a decision to withdraw care? So I definitely think that's one of the nuanced things about our job, is that we are going into situations and potentially bringing that outside point of view to some of these small community facilities. Not that completely different than this situation. So guys, we've gone 90 minutes. That's the end of it, end of the time. This was a phenomenal discussion. Thank you to everybody for joining us. Thank you to all the docs and the residents and for everybody that attended. Like I said, tell your friends about this. We'll get this up on YouTube and we'll get a link out. I also want to make a plug for, if anybody on here has not made the decision to come to MATSE, you should make that decision to come. Many of the docs that are on here, many of the folks that are on here will be presenting, and we'll be doing something along these lines on another discussion at the end of the day there with a group of phenomenal medical directors and with some interesting cases. So thank you again to everybody, and have a good rest of your day.
Thank you all very much. Always good to see you. Asa, I'm waiting for it.
Santa Ferrado Hospital
I'll be
Resuscitation
the
Medicine. Here we go, boys.
That's right. I'll be the unfunded medical director. We specialize in that, man. Let me know.
Take it
Don't
over
worry.
the world.
We're all unfunded.
Thank you, guys.
So good to see you, man.
Yeah, thanks, Sam. Great job
Yeah.
meeting you.
Awesome. Awesome.
All right, Sam, we'll see you next time, buddy.
See ya. Thanks,
All right,
guys.
man.
Later.
You got it.
Thank you.